It is a pleasure to join this educational program offered through the International Surgical Sleep Society. My name is Kezirian. As a sleep surgeon and past president of the ISSS, it is wonderful to see the wide array of lectures in the program on topics that are so important to sleep surgeons as our numbers grow and as we come together through the work of the organization. I will be speaking about how myofunctional therapy and lingual frenuloplasty are not currently appropriate treatment options for adults with obstructive sleep apnea. Importantly, I want to state that the conclusions of this talk are not just my opinion, but shared in a publication that conveys the assessment of a group of international experts and leaders in fields ranging from sleep dentistry to oral maxillofacial surgery to sleep medicine to sleep surgery. I have always been interested in new therapies, not limited to surgery, and I work with a number of companies and have a few patents myself. However, I will not be discussing any products related to these involvements with companies or my patents. After providing some background, I will go through the systematic review that is often cited by proponents of myofunctional therapy for sleep apnea, and then discuss some of the individual studies in this field, summing up with conclusions that reflect the broader opinion of an array of leaders in the sleep community. I want to start by saying that I'm very open to new ideas, but do require thorough studies before using these ideas to treat patients. I've been involved with some unorthodox but intriguing ideas where I have often been responsible for developing studies to evaluate them carefully before I, or really anyone, offers them up as treatment for adults with a potentially serious medical disorder like obstructive sleep apnea. This kind of study has not been done for oral myofunctional therapy or frenuloplasty. In particular, I am extremely interested in exercise-based approaches for sleep apnea, of which oral myofunctional therapy is one type, and I have given many talks on novel therapies including exercise-based approaches, so I would say that I have a far deeper understanding than the average sleep surgeon in this area. Part of this comes from many trips for sleep conferences in Brazil, where much of this work has been done, allowing me to meet and come to know well the sleep medicine teams that have conducted the studies of exercise-based approaches. Oral myofunctional therapy, or OMT, includes exercises from speech-language pathology to address speech and swallowing disorders that may relate to poor function or coordination of muscles of the tongue, throat, and face. Exercises have been proposed for speech and dental problems, and many of them are mobility exercises or stretching, or focused on low-intensity movements or muscle contraction. OMT as a discipline has been around for many years. I do not mean to criticize the field as a whole, but I've come to understand that the field is controversial, with different approaches within the field, as well as skepticism coming from other groups, including from many in speech-language pathology. We will talk later about an intriguing study published in 2009 of exercises for sleep apnea. And it was after this publication that certain people within the field of OMT looked to expand their scope of practice to treat obstructive sleep apnea and snoring. This spurred the activities of groups like the Academy of Orofacial Myofunctional Therapy and Academy of Applied Myofunctional Sciences, which sound like pretty impressive names and very official until you realize that they were founded by the same people, primarily to put on courses without any real science focus. I gave some talks a few years ago at a course offered by the Academy of Orofacial Myofunctional Therapy, where I was honestly shocked to see how they were selling OMT as a treatment for obstructive sleep apnea and snoring. The attendees came from various backgrounds such as speech-language pathology or dental hygiene, and the course leaders instructed attendees that they could go out and start treating sleep apnea patients with any of a long list of exercises developed for completely different purposes. They could choose these exercises without any guidance on how to do this, because there were, and are, no studies that provide any real guidance or foundation to doing so. These organizations, really these few people that run these organizations, have started holding all sorts of courses all around the world, selling them as a way for attendees to start treating sleep apnea. The reality is that there is no solid evidence supporting the use of OMT for adults with obstructive sleep apnea. In fact, some leaders in the OMT community have confided in me that they feel that those advancing OMT as a treatment for adults with sleep apnea are actually damaging the entire field of OMT by discrediting it. I do not mean to attack OMT, as these organizations and the individuals peddling OMT for sleep apnea do not represent OMT as a whole. The purpose of this talk is to look more closely at the actual evidence and explain why I and others feel so strongly. In short, there are many studies clearly supporting the value of OMT in specific conditions, but not in adults with obstructive sleep apnea. There is a common saying among pediatricians that children are not just little adults, meaning that children have unique features that really affect not only the presentation of the medical condition, but also the benefit of certain treatments. In short, one should not just take treatments that have shown benefit in adults and assume they will work in children. I have turned this around to state that adults are not just big children, meaning that one should not just take studies performed in children and assume the same effects will be seen in adults. Ankyloglossia, or tongue tie, is important in children. Nobody would dispute that. Nasal obstruction and mouth breathing may have an unfavorable impact on facial development based on some fairly old studies performed in non-human primates. This has led some to suggest that ankyloglossia and the so-called tongue position has an important role in facial development, a theory that is possibly true, but is definitely unproven. Almost all the literature that is cited about tongue position, OMT, ankyloglossia, and frenuloplasty is related to children and facial development. But we're talking about adults with obstructive sleep apnea. In adults, the bony growth plates have fused in the face because numerous fundamental studies of facial development have shown that this happens during the teen years, earlier in females than males. This is all pretty well documented and proven. There is no evidence that taking adults and trying to teach a different resting position of the tongue, whether through OMT or any other approach, treating ankyloglossia or performing frenuloplasty, does anything to change the facial skeleton. In fact, we would expect that this is impossible because of the fusion of bony growth plates that has already occurred. The result is that the pediatric studies that are cited to support OMT and frenuloplasty are just not relevant to the adult who has OSA currently. You cannot just unfuse the bony growth plates or turn back the clock to childhood for a patient to modify their development. It is just not possible based on everything that is known about bone growth and bone biology. Saruj Zaghi and I have shared slides so that we could have a real pro-con discussion, so I will review some areas of agreement. First, mouth breathing is unfavorable for obstructive sleep apnea, or technically for sleep disordered breathing. There are multiple potential mechanisms that have been studied. One is the fact that mouth breathing often occurs with nasal obstruction, and that obstruction of the upper airway is not ideal. Mouth breathing is also associated with posterior displacement of the tongue, a mechanical effect that occurs because the mandible swings down and back with mouth opening, moving the tongue with it. Finally, there are some reflexes that help to maintain an open pharyngeal airway that depend on airflow through the nose, such that mouth breathing may decrease the reflex activation of pharyngeal dilator muscles. I have included a reference to a review article where I was a co-author, but this was neither the first nor the last review article to summarize the literature on this topic. We also agree that the tongue is a major source of airway obstruction for many adults with obstructive sleep apnea. However, we disagree in a number of areas that are unproven. There is just no evidence to support the idea that OMT can convert someone from mouth breathing to nasal breathing. You can do all sorts of nasal breathing exercises, but I have never seen studies showing this effect. Focusing on tongue position with quote-unquote exercises during the day have never been shown to impact tongue position during sleep. It has just never been shown. Furthermore, the treatment of ankyloglossia in adults, whether with frenuloplasty or anything else, has never been shown to affect tongue position during sleep. Lastly, there are no studies showing that frenuloplasty combined with OMT is a treatment for adults with obstructive sleep apnea, making frenuloplasty an especially unproven approach. The idea that OMT and frenuloplasty are treatments for adults with obstructive sleep apnea would require proving these, and we are not even close. Now that we know what has not been studied, let's look at the studies that do exist. The exercise-based approaches that have been proposed for obstructive sleep apnea fall into three very different categories. One of the first studies suggesting that exercises of the muscles in the oral cavity was helpful for sleep apnea was a Swiss study of playing the didgeridoo. The didgeridoo is an Australian Aboriginal instrument requiring what is called circular breathing, or breathing in through the nose and out through the mouth at the same time as part of playing the instrument. This requires activation of the soft palate muscles to advance the soft palate and open the velopharynx to allow airflow from the nose to the oral cavity, effectively exercising the soft palate muscles. A didgeridoo instructor apparently had feedback from some students that their sleep quality and snoring improved, so they performed a small randomized trial showing some improvement in sleep apnea. This was exercising while playing an instrument, but some studies have explicitly studied exercises just for the sake of treating sleep apnea. The second category of exercise-based approaches includes some studies that have examined a specific exercise protocol, either using a single exercise or, in two studies, a group of exercises. These studies are in one category here, but really, each exercise protocol is very different, such that you cannot just combine all these results. Each exercise protocol has to be considered on its own in evaluating results. I will discuss the Guimaraes study later in more detail because it was such an important study in this area. The third category is a completely different approach that is advocated by most OMT providers in their courses for the treatment of obstructive sleep apnea, in which there is a provider-selected exercise program without a clear rationale for choosing these exercises and no specific protocol or method to select them. The result is that every practitioner can select whatever exercises they want without any guidance. This seems bizarre and not in a good way, and it seems so unscientific to me, and I've written before how I think this is not appropriate. I will review those two studies in this category later, but I will just say that these studies never discuss what exercises are used and how the exercises are chosen, making it impossible to use these studies in any meaningful way to treat patients, because a reader could have no idea what was actually done to treat the participants in the study. Because these approaches are completely different, you should never combine studies of them into a single systematic review and pretend to show what exercises can achieve. That is like saying you want to know whether sleep surgery is helpful and then combining results of all surgical procedures in a single systematic review. All surgical procedures are not the same, and all exercises and uses of exercises are not the same. Unfortunately, this is exactly what was done in the systematic review of myofunctional therapy that is referenced by Sarush Zaghi and so many others who argue that OMT is a reasonable treatment for adults with obstructive sleep apnea. This author group has published a number of systematic reviews on important topics in sleep medicine and surgery. Systematic reviews have a certain allure in the medical community. They are attractive to authors who raise important questions that they want to answer with data that seem readily available. Similarly, journals love to publish systematic reviews because they can be cited by other journal articles, raising what is called the impact factor of the journal, that is the major way people consider the quality of the journal. While I applaud the authors of this review for raising the important question of whether myofunctional therapy works, their eagerness to answer it with a systematic review led them to combine studies that should never have been combined, which is a fundamental scientific error. Just to be clear, when this article was published, I actually contacted many of the authors, whom I still consider as friends, to state these concerns, so I'm not talking about them behind their back. However, I think this work was just not performed correctly and should not be touted as proof of anything, really. And then even if we overlook this major issue, there is also the question of whether we should have confidence in the results of the review, which involves examining whether they followed accepted research methodologies, what are called the AMSTAR 2 criteria. Allow me to digress. I do not want to single out these authors, as there are problems with systematic reviews throughout the otolaryngology literature. In short, we are publishing systematic reviews and meta-analyses of extremely poor quality. In this paper here, We used the systematic review criteria, first published as AMSTAR in 2007 and then revised in 2017 as AMSTAR 2, to appraise the quality of systematic reviews and meta-analyses focused on interventions in the top 10 otolaryngology journals from 2012 to 2017. We involved a PhD medical librarian to appraise the quality of systematic reviews and meta-analyses in otolaryngology over this period. We performed a comprehensive search and focused on studies related to interventions. Here are some of what are called critical criteria in the AMSTAR 2. You can see that they are not unreasonable, requiring that you state that the methods were established prior to the review, had a comprehensive search strategy, listed studies and explained the exclusion of those that were excluded. I want to draw your attention to those in italics, which basically require that the authors evaluate the bias in the studies. Bias is very important because most studies are not randomized trials, leaving open the possibility for substantial bias that would, as you might expect, impact the findings of the review. If you are going to perform a systematic review and use non-randomized studies, as was the case for many of the studies in the myofunctional therapy review, you absolutely need to account for bias. Here are the results in our paper. What we found was that just about all of these systematic reviews in otolaryngology and sleep medicine surgery in particular had methods that provided critically low confidence in the results of the reviews. Basically, the systematic reviews and meta-analyses that we have published in otolaryngology are almost useless. So, the systematic review of myofunctional therapy was published in the journal Sleep and not included in our study because our study was limited to high-impact otolaryngology journals. However, I applied the same AMSTAR 2 criteria and found that it was in the same critically low confidence category. The biggest issue was the lack of an evaluation of bias in the multiple non-randomized studies that were included. I want to reiterate what is sort of a glaring scientific flaw, that they combined articles of different treatments. To take an example, you have an article from Suzuki that is a case series of mouth closure with force, just a single exercise, and they combined it with two Brazilian studies, one of a fixed exercise protocol and one with a variable protocol. The only conclusion that I would make is that the author raised an important question but did not answer it at all. Let's look at the high-quality studies of exercise-based approaches. I do not speak Portuguese, so I apologize for mispronouncing names. Guimaraes and a highly respected research group at INCOR in Sao Paulo published a randomized trial examining a specific protocol of exercises drawn from speech-language pathology that ostensibly were targeting the tongue, palate, and lateral pharyngeal walls. The randomized trial compared daily performance of 13 exercises against sham therapy of nasal breathing and nasal irrigations for a period of 3 months, with a total of 31 study participants with moderate obstructive sleep apnea and body mass index less than 40. Here are their results for the apnea-hypopnea index. On the left side is the control group, and there is no change, whereas on the right side with treatment, there was a decrease in the apnea-hypopnea index. The authors did not present the proportion who would be considered as having a response, but 2/3 of the participants shifted from moderate obstructive sleep apnea to mild or no obstructive sleep apnea after treatment, with greater improvements in the REM apnea-hypopnea index and no change in body mass index. If that was all there was, I would not be all that impressed, as there was always some night-to-night variation in sleep studies that could account for at least some of these changes. What was unique about this study was that they also measured neck circumference at baseline and at the end of the study, and showed that the change in apnea-hypopnea index was associated with the change in neck circumference, both in the control group in the solid circles and the treatment group, the open circles. You can see this on the graph shown here, where the change in neck circumference is on the y-axis and the change in the apnea-hypopnea index is on the x-axis. It is basically better to be towards the left side of the graph, and you can see that these study participants were more likely to be in the treatment group, the open circles, and have a decrease in their neck circumference. This was important because it showed a potential mechanism to explain these changes in the apnea-hypopnea index and why it might just be more than random variation in sleep study results. You might ask why this never caught on. Well, there were a few challenges. The first was that there were 13 exercises, making it difficult for anyone to want to perform this many daily. Also, some of the exercises were complex, making it difficult to perform them properly. Finally, it was never clear how exactly to select the patients that might benefit from this approach in the first place. Giaferia examined the role of provider-selected exercises, what is closer to OMT. In a group of 27 study participants who utilized a wide range of exercises, provider-selected, with no specific information about the actual exercises that were used, there was a decrease in the apnea-hypopnea index, although half of the change disappeared 3 months after discontinuation of the exercises. This partial return of the apnea-hypopnea index could mean either that there was some lasting benefit at that time, or that some of the decrease in the apnea-hypopnea index that occurred with exercises was not an actual change, but just a regression to the mean. We can never know or study this again to learn more because we have no idea how or what exercises were used. Of note, there was an increase in CPAP adherence with OMT, although that might just be a classic example of those that receive more care achieving better health outcomes. The group at INCOR in Sao Paulo that initially studied the fixed exercise protocol then performed a randomized controlled trial of provider-selected exercises. This time, there was no change in the apnea-hypopnea index, although again, we have no information about the exercises that were used and how they were selected. Interestingly, instead of highlighting the fact that they did not improve obstructive sleep apnea, the authors chose to showcase changes in subjective ratings of snoring in their title. I will talk about subjective assessment of snoring on the next slide, but as far as obstructive sleep apnea, this is a negative study, showing that provider-selected exercises, at least in this study, have no benefit. At best, it emphasizes the importance of a protocol for selecting exercises or the use of a fixed set of exercises. Joachim Maurer and the team at Mannheim showed us how misleading subjective assessments of snoring can be in a study of the pillar procedure many years ago. At time points ranging from 90 days to 1 year after the pillar procedure, they showed consistent subjective improvements in snoring at all time points on visual analog scale ratings, improving from 7 to about 5. However, they also measured snoring outcomes objectively using the SNAP home sleep study system before and then 90 days after the pillar procedure. In these same patients that had subjective improvements in snoring, there were no changes in 5 different measures of snoring severity, including the number of snores, vibration frequency, proportion of palatal snoring, and loudness. So the previous study that touted the benefits of provider-selected exercises in improving subjective ratings of snoring is likely biased and cannot be considered a real benefit. Soroush Zaghi led the publication of a series of 348 cases and has presented this as a cohort study, which is a fairly high level of evidence and proof of benefit of OMT and frenuloplasty. But I have 2 major concerns. First, this is not a cohort or level 3 study, even though it is published as one. This journal is open to articles that are rejected by Laryngoscope, and my sense is that the editor just did not look carefully at the description of it as a cohort study, because I can tell you for sure that it is not a cohort study. This study does include a group of patients that in plain English would be called a cohort, but it is just a case series or level 4 study because it is a before versus after report of individuals without an evaluation of risk factors, outcomes, or different treatments. Again, this is not a cohort study, even though the journal allowed it to be presented as one. I've explained this to Soroush, and he understands this. It is not the higher quality evidence that a cohort study offers. Second, the study reports some subjective improvements in snoring and sleep quality in some of the patients. But as you just heard, this kind of outcome is too vague and prone to bias. There is no objective measurement of snoring or obstructive sleep apnea. So the bottom line is the study cannot be considered proof of any treatment benefits. There are some case reports of adult patients experiencing some benefits with OMT with or without frenuloplasty. But I also have numerous adults in my practice and many colleagues around the world with similar experiences with no benefit from lengthy, committed, and expensive treatment with OMT with or without frenuloplasty performed by leading practitioners in the field that head these organizations or teach these courses dedicated to OMT and frenuloplasty for adult obstructive sleep apnea. There are also unpublished studies, so we're talking about groups of study participants showing no benefit of exercises with or without frenuloplasty. It is time for all of us to speak up about unproven treatments. Adult patients with obstructive sleep apnea definitely need options, including non-invasive approaches. In many cases, these patients are desperate when they do not do well with CPAP or other therapies. There has been a surge in advertised yet unproven interventions, and it really is disturbing. The marketing has far outpaced the science. For example, with appliances advertised for facial growth in adults that are also completely unproven, but provided to patients at a cost of $50,000 US. I have seen this all for a few years, and I wrote about OMT and frenuloplasty on my little blog in 2018, saying much of what I am saying here. That there might be a role in children, but that there was no proven role in adults with obstructive sleep apnea. With my minuscule blog audience, I thought it might get read by my mother and 5 of her closest friends, because nobody, not even my own young children, pay attention to anything I have to say. Instead, there was a flood of angry feedback and comments on the blog and elsewhere online, saying that I was just a surgeon who wanted to badmouth everything other than surgery. I did actually hear from some leaders in OMT, expressing that they actually agreed with what I wrote and thought it was a disservice to patients with sleep apnea and to the field of OMT that providers were out there marketing themselves as able to treat sleep apnea when no evidence existed. However, the overall tone was definitely one of anger. I engaged as many people as I could, going to their Facebook group once invited and answering all posts, hoping this would spur research, just as so many have critiqued sleep surgery as I still do, and have led to research in our own field. Instead, here we are 2 years later, with plenty of marketing and pretty much no more research. Christian Guillemot himself was a major proponent of OMT who has sadly passed away. But after my blog post, he actually commented with a long post about how I was wrong. Yet I was disappointed that he could only cite pediatric studies in an attempt to refute me. In essence, I was right in thinking that there was no evidence in adults. I will just say that some people who admired him, including me but also others, think that this is one area where he did real harm to adult obstructive sleep apnea patients. As I mentioned before, these are not just my opinions. Some of us have decided that it's time to speak out against OMT, frenuloplasty, and many other unproven treatments. Experts that you can see here, listed from sleep dentistry, oral maxillofacial surgery, sleep medicine, and sleep surgery, have written this paper because we are disturbed by the growth in the marketing of products where it's a complete or almost complete lack of high-quality, peer-reviewed, objective evidence of benefit in obstructive sleep apnea. For OMT, you can see the literature is almost non-existent when it comes to adults with sleep apnea. Directly from the paper, we make the statement that OMT and frenuloplasty are not proven treatments for adults with OSA. They should not be offered as OSA treatment except in registered clinical trials where publication is required regardless of the study outcomes. In conclusion, the evidence for OMT and frenuloplasty where it exists is mostly pediatric and not relevant to adults. The systematic review that is proposed as proof of benefit has major methodology issues that give one critically low confidence in the results, not to mention the fundamental scientific flaws that also make it tell us nothing about OMT. There are some studies of single exercises, but really 2 studies of fixed exercise protocols that show some benefit in obstructive sleep apnea, although you cannot really combine these results to see that exercises work because the exercises used in these studies were very different. There are 2 studies of provider-selected exercises that have very different results. Again, you cannot know what was done right or wrong because there is no information about what was done for the study participants. Adult obstructive sleep apnea is a potentially serious medical disorder that demands treatments that actually work. Until there is clear evidence of benefits, OMT and frenuloplasty should not be considered as appropriate treatment options for adult obstructive sleep apnea.